Okay, welcome to episode 2 of the Future Proof PT podcast. It's a mouthful. I have to get used to saying it. I'm here again with my co-host, Alex Bendersky, and we thought a great use of today's second podcast would be to allow me to interview Alex a bit about his time at the Combined Sections meeting for physical therapists this past week. And I think he just returned home yesterday, right, Alex?
Technically before midnight, so it was yesterday.
Okay. So we'll talk a little bit about some just high-level takeaways from CSM, and then touch on a couple of different topics that sort of came up from being at CSM. So just to tell you them in advance, to listen for them, we're going to talk a little bit about the essence of physical therapy, and Alex will get into what that is. And then the idea of the old guard in the physical therapy profession versus the new guard and what that means, and the tension that we sometimes sense, and kind of how we might want to think about that. And then a little bit about physical therapists, physical therapist assistants moving into non-clinical roles, to what they think are greener pastures, but are they really greener pastures? What do we need to do to keep more physical therapists that want to be in clinical care, and why? All right, Alex, so tell me and tell our audience a little bit about CSM this year and just some high-level takeaways.
Yeah, so thank you, Dana. Thank you for your time. I appreciate this, the avenue to have a voice, right? I think it was wonderful. So out of all the CSMs, you definitely see continued growth and continued investment from the ancillary industry into this musculoskeletal space. So you just see more vendors, larger avenues, more higher level attendance, and definitely more thrown into the mix to attract clinicians to these specific organizations. So if we can count by the number of happy hours sponsored by legacy PT clinics, that this has been the most rewarding one. There's pretty much one for every legacy clinic, which reflects, right, the difficulty attracting staff. But it's definitely an excellent thought experiment about how the vendors view musculoskeletal industry and how the attendees view the musculoskeletal industry. And you have this ever-present tension point between the vendors, which see physical therapy as this potential revenue generator for their products or their services. And you see the clinicians, academics, students who attend this to gain knowledge, expertise, or to just rub shoulders and gain connections and network with other clinicians. And there's still, I think, lack of pure understanding of what is the essence of, I would say, physical therapy, but really I think applies to allied health sciences, where the industry is trying to create these solutions that will either supplement or complement in-person care without actually understanding the true, I hate to use the word magic, but the true mechanism of this clinical encounter that is involved in allied health sciences. So you see a proliferation of these computer vision providers that have been there before, but now they're becoming a little bit more sophisticated. The technology is becoming more complex. The technology is also becoming more mature, where you no longer have this amateur looking game, but you have these really high level AI supported computer vision products and processes that are designed and provided to take the exercise to the next level, to engage patients to the next level. But I think the way the systems are designed, they are creating this now a separation from, like, a PT no longer has to take care of exercise with a patient. Our system will. The reality is, right, that's the essence of physical therapy, is not somebody counting repetitions, but the actual engagement and encounters and what you would call is patient-centeredness that occurs during that traditional visit that doesn't need to be supplemented by technology. You can be supported, but this whole essence, I think, of clinical care provision, that as the old APT logo, like the art of caring, the science of knowledge, or whatever that logo was for PT, right? Yeah, I think the art of caring cannot be reproduced by high-level technology, nor complemented. And so we're doing a decent job of validating and creating the science, but the art still needs to be, I think, appreciated in order for that essence of clinical encounter in the musculoskeletal space to be embraced.
Let me just ask you a clarifying question, because not being, living and breathing PT on a day-to-day basis, I'm not sure that I know, and maybe some of our listeners don't, what computer vision technology is. Can you explain it for me?
Yeah, so there's these systems that, well, let me go, I guess, a step back. Computer vision is a form of artificial intelligence where these computer models and AI models that recognize movement and are able to quantify and break down movements into specific parts. It is a large part of these emerging high-level technology systems that can detect anomalies and can also detect and monitor quantitative, qualitative movement, which can then be used as a resource for qualitative exercise performance. So these systems can use algorithms that both look at the movement from the qualitative standpoint, so just the range of motion, the precision, and quantitative performance, where you can count repetitions, you can set different measures and parameters based on what you want the patient to do. So computer vision itself is a form of technology. Computer vision applied to musculoskeletal care is being used as either something that you can use with patients as an aftercare program to improve their exercise performance, or you can be used as a through care program, where once you are done doing what you do in a patient encounter, you then outsource the patient onto that system instead of outsourcing the patient to a technician or whoever else.
Okay, that makes a lot of sense. So that's kind of like a technology that's monitoring a patient doing therapeutic exercise or something that they've been prescribed to do, and it's monitoring and giving them feedback, or does the therapist have to give them feedback?
So it can be both, right? You can give the patient immediate feedback. So based on a criteria, so based on the boundaries that you set and the framing that you provide to the system. So whatever measures are, the program then will provide feedback to the patient by either creating like a sound, a visual cue, or some kind of a feedback mechanism following the performance of an exercise. After the completion of the exercise engagement, the system itself will give a qualitative report to the therapist that the therapist can then interpret. So I think that's where I think that system can be optimized to actually provide an immense value to a clinician, because you're not relying on arbitrary visual perspective of like, I think you did this way. You're getting a high level, really granular clinical data based on somebody's performance that you can then break down from visit to visit through the length of the engagement to see whether somebody's performance is improving based on what you want to see. So when you look at the qualitative performance, you just basic range, right? Are you able to achieve the range with a great movement? Other qualitative performance is speed, efficiency, energy provision. Other parts could be just much simpler. If you want somebody's depth of squat to be pressed a certain degree, right, and number of repetitions, you will keep you honest as a patient. So if you set the engagement at when you 15 repetitions, it will count the repetitions for you to the depth. And if you're not there, it will ding and penalize you. And then it will incentivize you to go to a certain point. Or because these systems are being used in other industries. And like this is in essence, your robotics, right? Where these systems are looking into the efficiency of other systems, but applied to a human performance.
And so my next thought process around this technology is this brings out and highlights one of the things that's challenging about getting patients to finish their plan of care all the time is the ability to give consistent feedback and some level of accountability between sessions, right? One of the things that I found most frustrating as a therapist, and, I really didn't know how to solve for, was knowing that the time I had with the patient hands-on in person was one tiny fraction of the rest of their week and their month. And that if they didn't digest, if I wasn't able to convince them that they had to continue to be consistent and they had to, engage in certain behaviors that would lead to the goals, that it wasn't going to be up to me to accomplish those things that they had to do on their own. If I couldn't get them to know right from the beginning that they had to own that, I knew I wasn't going to be able to achieve those outcomes. And that certain personality types, it can be difficult to motivate them to do something, especially if they're uncomfortable, especially if they say, wait a second, how did I do that again? And they don't have that feedback. So it's interesting. This I can see why this is helpful for therapists. But I think the other takeaway here that from what we brought up before is the art of therapy is as important as science. And one of the reasons I am trying to get therapists to own and embrace what a skill that is, being able to engage patients to change their behavior. This is not something that loads of healthcare professionals are great at. And if we don't own it, other inventors and entrepreneurs will figure out how to use us and in order to accomplish and sell their product. I'm grateful for those products, but as a therapy community, I'd love for us to like understand why these things are being created, who has the incentive. Just sell these products, but how do we engage in them to help grow and expand the profession? I don't know if that resonates, but that's sort of
I think that that's actually a perfect review of that system, right, in play, and goes back into the essence of physical therapy or essence of allied health sciences, which is, I think, how do you create an economic benchmark for therapeutic alliance between a therapist and a patient? Like, can you really create a algorithm or formula that best represents the therapeutic alliance? And is that formula then replaceable by a system like the one that uses computer vision, which is more of a modality, or like the one that can be, again, digitized so that encounter can be more automated through other systems that are not human based? And that's where I think that is slightly lost from the industry. The therapeutic alliance between two individuals, two humans, one that is in need of care and one that is in the provision of care, can be digitized to a point, but that digitization needs to be something that is a value add, not a supplement. And I think most of the systems are designed and built to supplement human-based care because of the current economic tension point within the industry, where we just don't have enough resources, we don't have enough staff, we don't have enough time with the patient. Let the machine do that for you. And that takes away from that alliance, which is, I think, the essence of encounter. That is why an individual comes into your clinic. The individual comes to your clinic to interact with another human. That, in a way, if you look at all the studies that look at the biggest predictor of a successful clinical encounter, is that therapeutic alliance. Beyond anything else, beyond the clinical provision, beyond clinical guidance, or the adherence to best practices, which are also incredibly important. But that alliance between I, the consumer, and you, the provider, is a huge predictor of a successful clinical encounter, for better and worse, right? That, I think, is the biggest separator of our industry from traditional medical care, where I know if I'm a surgeon, there's a surgical technique. I will apply either technique A, B, or C with a predictable outcomes to a point, like short of any ancillary negative outcomes with infection or with poor response to the surgical care. Like if I need to get my gallbladder out, there's a couple of techniques that can be executed, and my gallbladder will be out. In physical therapy, I think that human nature of care provision is about that encounter between two humans. So these systems, I think that the opportunity lost is as the systems are being optimized to take away from the alliance instead of to actually support the alliance, is that one tension point that may need to be resolved in the future for these systems to be more readily engaged and applied in the traditional care.
this, I think, to your point, is really what separates something like a surgeon is paid based upon successful completion of a surgery and not the follow through, not how they rehab, none of that, how they recover. It's just completing the procedure, billing for the code, being paid handsomely, usually, and being done with it. Whereas, not, it's a hindrance in some ways because it means that part of our talent and our ability and skill set that we have to hone is being great at engagement and in helping people engage in behavior change and vary that and modulate that based upon personality. There's a whole lot of psychology involved in being a successful therapist. And that lack of control is one of the things that's very frustrating to a lot of therapists. Besides the reimbursement issues we talk about a lot, I think some of what leads to a lot of burnout is, you can give it your all in hands-on care. If your patient, for one of the myriad reasons they don't show up to complete their plan of care or able to comply because of, their own self-drivers and many other reasons, you don't get that same feedback all the time, right? Where, if you're a physician and you're prescribing or you're operating, or you're doing a test, you don't need much from the patient, but we need engagement from our patients or we don't get anything in return. And I don't know much about who has developed these solutions, but they realize that this is a limiting factor to therapy, and they realize that there's a solution that they could create. And then what does that mean for us as physical therapists, either using this or, thinking about how this is going to lead to changes in the profession, positive and negative?
Yeah, no, definitely. I think that's how do you explain it to a payer that at least a third of the predictive value of the clinical encounter has to do with this arbitrary subjective human factor. And how do you quantify the arbitrary human subjective factor to maximize reimbursement, right? So as a payer, what you were referencing, if you're a surgeon, if you have lower rates of infection and a faster recovery and fewer hospitalizations, you are a good surgeon. Therefore, you get bonus, right? You get the extra value. As a physical therapist, if you can, we've always been quantified based on the number of visits per encounter or per diagnosis. But that itself is still something that can be, I guess, perverse, where I can trace back in my ancient times, one of the first large systems I was a part of as just a clinician and as a clinic director was to really maximize the KPI that was called SFQ, which is script frequency quotient, or number of visits per script, right? So to me, there was nothing more arbitrary and more perverse than to maximize the number of visits per script, independent of other factors that would predict the actual clinical efficacy for those visits. And so I guess you had a training of the clinicians to how to, like, the tools and the levers to maximize patients' desire to come back, which is, well, ask about other disorders, ask about other diagnoses. Focus on things that are, to me as a clinician, are a little arbitrary, which is the non-controllable objective factors like posture or gait or locomotion or efficiency, which is fine, but is it really ethical? And I think that's, so to a payer, how do you expect them to respect these boundaries when you know that the organizations are actually optimizing something that leads to what I would see as a low value care, because we're increasing engagement, but we're a low value engagement. And that's
Where something like surgical care, just to inject a little bit of value-based care here that I think is worth bringing up, for surgeons, they build their code, and that code doesn't vary. It's the same code that surgeon B uses for surgeon A, and they're going to be reimbursed the same. But if their outcomes aren't as good, now that payers are looking very carefully at that, and providers taking risk, like a primary care practice, they're looking directly at all of the outcomes and quality and cost for anybody who had, any surgeon that they're looking to bring into a network, to make a preferred provider, to give them a contract, and to change their referral patterns. So I would argue that since we're already seeing this in the surgical space and the physician space, where we can differentiate the value of a practice, while right now the vast majority of therapists are not seeing this impact their practice at all yet. It is only a matter of time. It is going to happen. It's a matter of believing it's going to happen and understanding what value looks like. To your point, I can't believe the script frequency quotient. I mean, they put quotient in there as if it's like some scientific calculation, right? But in the future, and we're already seeing it now, there's already novel contracts. It's just, the day-to-day therapists owning individual practices aren't seeing much of it. You'll be rewarded for the adherence to plan, the accurate and appropriate amount of in-person visits, coupled with how you keep them engaged and how you help them improve or change their behavior in a way that allows them to fully heal and then maintain that healing for long periods of time, so it doesn't lead to a relapse and they end up with more acute and specialist care. Those are the kinds of metrics that those in value-based contracts care about. One last thing I'll say about this is therapists push back quite a bit when I go into this, like, it's going to happen, it's going to happen. The reason right now we're not getting a lot of attention by most payers is we're such a fractional, tiny fraction of spend of non-physician allied health spend is its own tiny bucket, and physical therapist care is an even teeny tinier bucket in that tiny bucket to begin with. So we're not top of mind because we're not a big lever. The only way we're going to show our value is to show how we impact the other really costly levers. Then our value goes up. Our value individually is not readily seen looking at claims data. It has to be how we impact the high cost care through the continuum. That's where we're going to shine. And the therapists that figure this out first actively work towards this way of practicing and using that data to get into novel contracts proactively are the ones who are going to succeed. And to go right back to the start and then to our next point, this kind of practice will retain therapists, right? Where therapists are where they're being praised and where they're being rewarded financially for providing the right care, for engaging patients, and for dosing appropriately, it reduces that chance of moral injury and of burnout, and they reduces wait list time, improves access, all of those things, and will retain more therapists in this good profession for much longer, right?
Yeah.
So
I think, being a little bit more empirically driven, we have to have better economic evaluations of the externalities
yes.
to our provision of care, where you already have the downstream utilization and you have quality of life years being examined based on the first encounter standpoint, right? But I think that there's even a higher complexity and a higher level ecosystem that is being met by our engagement that is not accounted for economically, at least in terms of healthcare economics, that needs to be addressed. But to counter my own argument, as long as we have these script frequency quotient, you're always going to have a perverse way of capitalizing on these systems for short-term gain, which once the economic lever shifts and we're going to be scrutinized more readily for the frequency of encounters and rewarded for fewer visits, especially in these value-based systems, then you will automatically have the same providers shift from incentivizing therapists to retain patients for a longer period of time by creating these low value provisions to creating incentive levers for early dismissal before the individual is ready. And then how do we safeguard and protect both the therapist and the patients from these levers? And still, you're right, retain these clinicians, reduce the emotional burden, reduce the gain. I think there's always an interesting conflict between the biggest difference between lies and BS, right? So BS is a true term. And so liars know what the true factor and the true vector of is. And BSers don't know or don't care what the true vector of truth is. They're just going to continue on their path. And I think that the PT industry has had a large infiltration of BS on a very high level that continues to play into that provision factor where there's not even an awareness of single truth, but not a care to be aware of the single point of truth. So I think if that's the case, you will see that in the pendular shift, even if the payers recognize their value and they're going to say, well, look, we'll incentivize you to provide care, especially as a primary care provider, but you need to do it under certain constraints, which could be visit constraints, which could be capital constraints. And then you're going to have people who make decisions on behalf of the practitioner will just shift the lever towards you only have 4 visits to take care of this medically complex patient. And in 4 visits, I expect you to capitalize fewer number of units because that's going to help us retain higher amount of value, right? But still, then you go to the essence of physical therapy, which is that how can we maximize this art of caring? Again, not really arbitrary, but poorly quantified art of caring in a clinical space to still provide this high value product, which comes with a therapeutic alliance and the point of engagement and an incentive and connection between the therapist and the patient.
And I think it's a good call out to point out that value-based care, when it comes to something like reduced volumes, when it's an arbitrary number of visits or an arbitrary quantity of reimbursement, is not the idea. The idea is, let me look at a parallel first to kind of explain what I mean by that. If many listeners are probably familiar with acute episodes of care programs, right? Someone has a hip fracture, total knee replacement, they're hospitalized. And then there's the total costs that are incurred over 90 days after the discharge. That cost actually spent is reconciled to what the anticipated cost should have been over 90 days. And that's how there's either a reward or a penalty for the total outcomes 3 months later. Where this is similar to the concern that you bring up in a hospital, let's say the hospital, average total knee replacement length of stay is 3 days, let's say it's 2 days. That's their goal length of stay. In the case of in a value-based care contract, if we know that there's something that needs to be resolved and they need to stay longer, even though that hurts, right? In a hospital, you want them out as quickly as you can financially because that's how you maximize the amount you keep from the DRG. In a value-based care arrangement, when there's a genuine clinical functional reason for a number of things could qualify to keep them an extra day, when you know that will reduce the total spend in the this episode, there's an incentive to keep them. So one example of where something like this came up was the total knee replacement patient. We knew that in some cases we could have everything planned for a home discharge, either home health after a total knee or sometimes direct to outpatient PT at home. But there was something that was really needed to be resolved. Either they had an issue with the anesthesia or with nausea, or they were, needed to build up a little bit more confidence that we were better off keeping them in the hospital another day than sending them to an inpatient site of care for post-acute. So volume is modulated by what the clinical picture of the individual is and of the team and the team's assessment, and comparing that to, what changing that trajectory could mean for the total outcome, cost, and quality for the patient. So in other words, if you think about therapy, low back pain, let's say in the old world, we were told you can only have 6 visits. That's the most you're going to get. And you can only have $1,000, totally arbitrary numbers here. That is, nobody should be in support of that. No therapists want that, right? We don't want to be limited on some arbitrary number or dollar amount. But to say, we are going to give you a starting reimbursement of this to use that money as you want. And then when we get to the end of the calendar year, we're going to go back and we're going to look at how you performed compared to a total time period of an episode performed compared to what we anticipated, looking at the individual factors. And there's ways that they risk adjust and identify like an anticipated spend. And then we're going to give you a bonus at the end of that. We're going to reimburse you not for what you spent individually. We're going to reimburse you based upon what happened after that, in the total course of, and for X number of days or months after that condition is resolved. We're going to look back and say, well, maybe you saw them 15 times. We really don't care. But what we know is by you seeing them or whatever it is that you did to engage them and keep them in care, it avoided what a percentage of what we anticipate in the past, which is typically they're still going to get an MRI regardless of your care. They're still going to go see an orthopedic surgeon regardless of your care. They're still going to end up with some intervention. Your work is to avoid what is not necessary, to put more effort in being exact about what's best for each patient. Very, very different from the old world of capitation. We don't want that. No one wants that. No one. Did that make sense?
Oh, that's fascinating, right? So that's really interesting, right? And it's really fascinating about these levers that the payers care about, which is the risk-based model. So how do we prevent the risk from these higher cost, lower efficiency clinical modalities being used based upon the first encounter? The question here is that the source of truth. How transparent are the payers about their sources of truth that they're looking for? What are the levers that they look for? And do they make them available for providers to align with? The second point is, how do these levers become the sources of truth? Who is the decision maker that these 5 factors are most important to us, that we want to protect this individual from this radiology, right? So any radiographic use leads to a higher long-term utilization. So how do we protect from that? How do we protect from these high-cost encounters, which are specialist encounters? And how do we keep people within a primary care model? Like that I think is really so important, that provision of honest, transparent sources of truth that everybody can align to, because that is what it is, right? And then from there, you can start building these pathways and models that align for these high efficiency, high value care. Because efficiency is, you're right, it should never be capitated based on money, should never be capitated based on visits, because there's just such a large spectrum of what is normal based on the individual. But if you don't know what the one source of truth is, if you don't know what you're looking for, and you continue to provide care that's only oriented towards a patient-reported outcome measure for this one individual, potentially, which is not even the case, right? But that's at least some systems are designed for that. In the ideal world, there's going to be a higher alignment for patient-reported outcome measures. What else is there to do? Then you're just going to continue to provide this very diverse, arbitrary care based on the organization, based on the system that you land in, because maybe your system aligns to one specific philosophy and your care is going to continue indefinitely because they believe that they have to maintain their contact point with you. Or you're going to align with a different system that sees autonomy as the greatest gift to physical therapy. So they're going to give you education. They're going to give you a package. and they're going to boot you on your own. And both are going to be deemed as a clinical encounter. And to the payer, they're both going to see the same as a clinical encounter. So that's like that would be my rebuttal to that source of truth that from the downstream.
Mm-hmm. Yeah. One good analogy to look at and to know what's possible here for therapists. This is being done already. And I'll tell you a little bit about how they're coming up with what these targets are. But if you look at what's happening with advanced primary care practices that are taking on full risk, and just for the audience to know what that means, again, it means that for a population of patients, the payer will take the dollars that they have to spend. So the payer every year has a lump of dollars, has to be distributed among all the people that they're insuring. They take a very high percentage of that, somewhere in the neighborhood of 85% is kind of the average, and they give it to the practice. And they say, now you're the payer. And you have to figure out how to use those dollars to prevent downstream, low value, low quality, poor quality of life care. And so with all of those dollars, they have to pay out the hospitalizations out of that money. They have to pay the post-acute care. And if that spend goes above what they gave them, they owe it back. But what we know, and it's being proven year after year after year, what we know is when you give that money to primary care up front and they build out teams, right? They stop worrying about frequency. They don't care about visit frequency. They care about giving every patient that they're responsible for exactly what they need. And that's sometimes community health workers going to the home, that social workers helping them sign up for X benefits, that transportation to get them to the practice, that's being available wide range of hours, that's hiring additional staff, that's lowering the ratio of docs and APPs to patients. They spend up to 4 times as much on each patient in primary care because the downstream impact on that is like 20-fold what they get back. And it's the same. We have to, I argue, as you heard it here. Well, I've said it many times in other venues, but I argue if we don't position ourselves as that, as we have someone with low back pain, simple example, and we give you X dollars to care for this patient for the course of the year, you're going to use those dollars. And then at the end, we're going to go back to what we consider the target price, right? They target a cost for, it can be for the entire year for a condition type. And we base that on and that they should be fully transparent with you about what data inputs go into that risk adjustment. We risk adjust each patient based upon a number of different factors. And then we're going to tell you what it is up front. And then we're going to tell you how we're going to reward you based upon whether or not that particular patient's year in caring for their low back pain was above or below what we anticipated because of their risk, right? So as long as what we've experienced, the parallel to primary care, what we've experienced in primary care is you give them what they need, the right communication, the right access, the right using technology, like the technology we talked about at the beginning, using RTM, the right dose, whatever it is, we don't mind spending it because we understand that we're going to get rewarded in the end based upon how that patient performs, not based upon the visit frequency. Visit frequency takes on an entirely different meaning. We want the right frequency. Maybe it means more visits. We hire community health workers and they help support that patient to be successful in their episode over time, or they're checking in, or we establish a system where every 2 weeks after they're discharged, we're doing outreach. Maybe it's text-based automated outreach. These are the levers that primary care is using. And primary care is seeing patients with back pain. They are seeing patients with arthritis that they think can avoid surgery. They're just not the right ones to be helping control that spend and get those outcomes. It's us. So either we level ourselves up as a profession and present ourselves as just part of the primary care team that's ideal in caring for all of these things. We're never going to have a different position in the minds of payers or providers that are taking on the action of a payer. They're responsible for spend, right?
So that's actually a perfect segue to that CSM, where I had a privilege of attending a talk. I think it's called the AIM study, but it is a study of VA patient population and healthcare utilization based on using a hybrid model. So looking into these individuals pursuing care, and they used the most rudimentary form of non-clinical encounter, which was a phone call, to continue to support and engage these individuals beyond the course of care. So I think in a different segment, in a different episode, we can definitely dig deeper into that study. But I believe it was Trevor Lentz and his team that just looked into a pretty substantial cohort over a pretty decent amount of time to show and to support that this hybrid care vicinity of, like, you don't need just clinical encounters, but you do need these touch points to provide care, to provide reassurance to these vulnerable individuals, to reduce the likelihood of them falling into these really, I guess, traps of healthcare systems, these high cost, low, poor outcome modalities. So there's a definite push this model of care, at least in the VA system, right, which is a very unique system. And we definitely probably should spend
Yes.
at least an hour looking into all the work from Daniel Rohn in a military system and PTs as PCPs.
Yep.
But there's a lot we can learn because it's already been done. But to go back to what you were saying, Dana, I think that that is exactly, it's a wonderful explanation that you have just done. And I hope that every listener will rewind and actually listen to what you just said a couple of times, because there's a lot of density to the information that you've provided. There's a lot of density towards the model that you're explaining that most clinicians don't understand, because the model that is ingrained in us through the fee-for-service model, which is just very rudimentary, like see patient, provide care, see patient, provide care, which does not orient itself to these rewards, regardless of the frequency and regardless of the volume. But there is poor awareness of the externalities and levers that you're trying to influence. You are still seeing it very much as a I know it works kind of model, or I'm going to provide care. If the patient is in the clinic, I'm going to provide care, regardless of whether they need it or not, right?
One final point before we move on to the next topic, and then we'll wrap it up. These entrepreneurs that are creating, venture capitalists that are funding the creation of these health tech solutions, like the one you described earlier, they're going directly to payers and saying, we will take risk on X patients, right? We, as the tech solution, we want to be a vendor to help you manage patients who see physical therapists, and we are going to take risk, and we are going to make XYZ promises for outcomes if you put us in as part of your network. So there's lots of different ways that they do this. But the point I would love for listeners to take away from this is how venture capital, because they see and understand the big picture and how to leverage value to payers, they're using the physical therapy professional community as tools for them to be successful in their venture. In other words, they can offer perks, and there's different ways that they can engage therapists to use the product, but they're not the ones that are the beneficiaries of changing the trajectory of dollars. The health tech entrepreneurs understand that what they're solving for and what they're creating has a strong ability to reduce the total cost of care for a condition. And they're selling that directly to payers, with us being just the users of the tech, not the ones that are benefiting from it financially. So we're in this passive position by and large. I'm sure there's exceptions where therapists are getting this, but we're being used as a tool for health tech entrepreneurs who know more than we do, who have learned about this, who understand the power of these solutions. And rather than just be a user of a point solution with our patients, where are we going directly as practices to the payers and be willing to use various tools that we engage with directly?
I think it makes perfect sense. Let me know if this is equivalent, but just over the weekend on the way home, I had a discussion with someone about that Richard Thaler's work on choice architecture, right, and nudge, and looking into externalities where there was a single experiment of how to reduce cost of cleaning men's bathrooms, and reduce the spillage from men's bathrooms. And so they produced this little graphic of a fly in a urinal, and they were able to significantly reduce the amount of external spillage from this process because they produced a single incentive to maintain better precision. So using physical therapists are that fly in the urinal that allows all of the larger stakeholders to maintain higher efficiency. And we are that fly that is just keeping the focus on the patient from going outside of the boundaries of that domain. So hopefully that's a equivalent analogy.
I think it is, right? Others know our value better than we do.
Yeah.
I argue part of that is because we're so used to living in our silos of care and don't have because of how our day-to-day schedules look, we can't see outside of that. But health tech does, payers do. And we're right now, it's almost likening if we allow this to happen and we are not the ones to benefit from it directly. It's like in a way that we're like technicians. We're necessary for this in order for this technology to be used and to be valuable. We're necessary, but we're not integral to the day-to-day care of musculoskeletal patients where we're the ones deciding these various tech tools will help us achieve better outcomes over the long term, and who gets the value out of that and how do we extract some of that value? Because there can be and is a tremendous amount of downstream value when it's removed, when you remove all that downstream spend. It goes to the providers giving that upstream care. We are sitting on the outside of this and not benefiting from it, right? And so I know I probably just said that, but just saying it in a slightly different way. We have to, if we don't start looking at what's around us and what payers are looking at and what health tech entrepreneurs are creating and how they're leveraging us to sell their solution, we're then not truly a part of the solution. We're just a lever in that solution.
We continue to be the fly in a urinal.
We're the fly in the urinal. Great.
We're proficient at collecting, but not necessarily understanding what our true aim is, right? Both aim literally and figuratively.
God.
No, that's wonderful. So yeah, really interesting.
It's wonderful that we got it out there. Now, we need listeners to say, this is a really good opportunity that is in front of me and I have to figure it out. That's really what we want to happen. So for the sake of time, Alex, can you, just to tack here to the old guard versus the new guard, can you tell me a little bit more about how you think about that? What does the old guard mean and sort of where do you see it maybe as a barrier for the profession?
Absolutely. So you look at the APTA as a structure and as an organization, right? And the leadership, I guess APTA being the guiding light for our professional community. And you look at the governance of APTA and the guidance of APTA and leadership over the last 20 to 30 years and how it has aligned with the best interest of our community, professional community. And then you look into that tension points from the people that have been guiding our professional community over this time versus the people that are emerging now in a leadership roles. I think that's the old guard versus new guard tension, where the new guard has a much better appreciation and understanding of these emerging technology levers and emerging practice levers. They can optimize our profession. And the old guard either has poor understanding, poor appreciation, or just ambivalence about these levers because of their orientation towards their original Magna Carta, original focus point, where they just continue to orient APTA and the community towards the true north, that the true north itself may have shifted since then. So that's at least to me, that was the permeable tension point, being in the CSM and being experiencing this huge differentiation between the young professionals, young clinicians, and what their interests are, and the traditional leaders in the APTA community that continue to drive the same message that they have been driving for a couple of decades now.
What is that message?
Which is right, like the physical therapy PT first, choose PT, I think it's a well-intentioned message that does not have a strong foundation because it has never been validated and there has never been a significant amount of capital investment into that message beyond the rudimentary choose PT first, right? Like unless you validate it, it's a slogan. And so the new guard is, I think, now in a way maybe not revolting, but pushing back against that slogan by creating other organizations or creating other points of contact. And I think you have seen this, we've discussed the emergence of other affiliations, PT affiliations that are trying to create a system for people who are frustrated with the old system. So that is that old guard, new guard tension point where I think the best leadership understands when there is a title change. The best leadership also understands when you have to accept new ideas, new thought paradigms, right? You see these how I'm trying to create a more politically correct statement, but you've seen the same ways of how organizations with antiquated leadership at the C level and fail to update their course tend to suffer financially because they just never update their organizational interest based on emerging new needs. And so, like, essentially a Kodak event where Kodak continues to create cameras using film instead of transitioning to digital,
Mhm.
or right, the Polaroid effect.
Toys R Us not figuring out how to be online and going under because of Amazon.
Yeah, like that. One of my wife's first employers out of college was Motorola, and so my wife worked on this foundational piece of equipment called the flip phone, right? And that was right about the time when Apple was coming out with the iPhone. And I just remember attending these holiday events where they're celebrating the flip phone and poo-pooing the iPhone, but instead of embracing it and saying like, hey, like it's a worthy competition. So that's the old guard continues to double down on the flip phone being like the Magna Carta. We'll continue to use PT flip phone because it works. And then the new guard sees it and like laughs at it because they have been using the iPhone now for years and they know that it's a better piece of technology. So it probably is not the most close orientation, but it's that like we need a leadership to understand and appreciate that there is an emergence of new leadership also that is pushing back, and it's real, and it is a contributor to some of the tension that it could be experienced at the CSM, and I think will continue to be experienced in a higher form as we move forward.
What I'm seeing online on these alternative organizations is not, I'm not seeing now that they're solving for what needs to be solved for. I think that this, the whole argument for choose PT first, that's been, I don't want to say flawed, but it's not been directed in the right place. In other words, consumers aren't getting this message because they're so oriented in American healthcare to physician. I see my physician first. And that study that the APT put out it was meant partially to highlight that, I would posit. And I'm frustrated a little bit by alternative organizations instead of looking to what is being developed and trying to support and embrace that and help drive some of that work in the right direction. We're focused on a lot of physician fee schedule advocacy, which is, in my argument, is not going to solve the problem that we actually have, which is our physician fee schedule fix is going to impact everyone, right? And if they fix it, if they fix the physician fee schedule short, long term, it's going to increase reimbursement to specialists the most. And then the volume of specialists is much higher. And we are a very, very tiny itty bitty fraction of that spend. And we're not the ones that are the reason this can't be passed. It's all of the spend elsewhere. So if we recognize that and we can elevate our profession to being one to help solve the overspend problem, and we can argue for the value of our codes needing to be higher if we're talking fee for service, that is a good argument to make and probably more appropriate targeted advocacy. But on top of that, it's really successfully participating in supporting team-based primary care, understanding how this works, and leveling ourselves up so that, as I've said many times, primary care needs to be a surrogate messenger. Presenting us as part of the primary care team will change all of the perception of our profession, no matter where you're practicing. If you're a specialist practicing pelvic health, or you're doing neurologic PT in the practice down the street, the perception needs to change, and perceptions don't change because of ads targeted at the public. Who's influencing the thinking of the consumer about their healthcare? They are oriented to their physician, their primary care doc, and in a lot of cases, their specialists, if they see them, and not to us. And like, we kind of have to get over our egos about this. I sense part of it is that's the problem. It's not an easy step maybe to think of ourselves as not positioning ourselves as in a solution that makes sense to the public, but more importantly, a solution that physicians, who should be our direct partners, need us to give the MSK and other physical therapy care to patients to avoid all of what they can't control, all of that downstream high spend. In order to control it, they can use physical therapy it's like 30% of patients in primary care are there for reasons that we are most appropriate for. We are part of the primary care team, but we have to embrace it and start putting ourselves in that position so that these other things can come to fruition.
Yeah, I think that is really wonderfully articulated, Dana. And that's exactly the point. That boasting, blasting to the public that choose PT without letting the therapist take ownership of that specific role is creating almost a wrongful message, because you're not creating a community of practitioners that are ready to accept this position. So that's really well said.
Thanks. I think we had maybe one before you talk about the book that you read on the flight home and some really great takeaways. The last we were going to mention is seeing that physical therapists are taking a lot of sales and kind of customer service, but that type of role versus where we're seeing physicians who leave clinical work being in more strategy, higher level roles where they're impacting, they're having a bigger impact on the healthcare industry. So can you just talk for a minute about that, Alex?
Yeah, I think that's so. Maybe we can make this to whoever is willing to give us their ear. That this could be a challenge for a week to give us some ideas or some thoughts of. It's a thought experiment. So how do we incentivize clinicians, talented clinicians that really deserve and need to be taking care of patients because their skill set and their talent is to provide care? How do we incentivize them to stay relevant in a clinical setting? It is a tension point where a clinical job pays you $100,000 a year and a sales job pays you $150,000 a year, just a figure of speech, right? And so that it's a significant increase in salary. And as dedicated as we are as clinicians, as philanthropic as we are, as charitable as we are, it's still very hard to overcome that significant increase in salary, short-term salary, when you know that your clinical job, especially year to year, does not have a lot of variability. What is the thought experiment? What are some of the secondary incentives we can provide in a traditional space to keep clinicians engaged in the clinical? So how do we engage this workplace autonomy, workplace culture that drives clinicians to be relevant clinically? So maybe we will leave this as it is and mention it again next week, but it is a true thought experiment, because that's like it goes against everything that the free market economics dictates, which is you should always accept a higher paying job. You should always go towards what carries a high level of reimbursement, regardless of the other levers, because ultimately you only have a limited finite time to control and to work. And if that finite time is not being used optimally, then you're not living up to the free market economics. You are being a, I guess, naive fool. So let's talk about this next week, but it really is that thought experiment. What is there left to do besides the fact that there's just, we economically cannot in a clinic provide the same type of salary that some of these sales positions provide, but we still need clinicians, especially great clinicians, to do what they do, which is provide clinical care. So yeah.
Love it. Okay. For next time. And then if, just to close it out, since you are an amazingly prolific reader and always have great takeaways, you told me before we got started, that a book by Bill Welsh, The Score Takes Care of Itself, and some really cool takeaways. You just started to mention them. So if you want to just go over them quickly for our listeners.
Perfect. I promise not to take more than a minute, but always look down on books written by sports coaches, because I think that philosophy and mantra a lot of times is very single point oriented and gets lost in the translation and all the sports cliches. But I think here that the overarching message, it really does resonate, which is the importance of having a strategy and the importance of sticking to that strategy long term, to understand that the need for consistency in your delivery, either delivery of a message, delivery of care, delivery of anything else, where the score takes care of itself if you're consistent in your execution. And the need for patience, need for I guess, the need for an individual to be patient with the process, but the process needs to be set up in a way, it needs to be created by the individual over time that is consistent with what the goals are. It is consistent with what the organizational goals are. Mm-hmm. So that score takes care of itself from one, like the phenomenology of one individual through their life experience. How can we adapt to it? And my lesson learned was that being impatient or being reactive, it underserves the larger theme, the larger need, which is to be patient with yourself and to be patient with your needs for the future. So a good book, because it's a quick book and it's also not a book that is overwhelmingly difficult to read. So it's a worthwhile course in leadership and course in consistency from one individual that unfortunately has passed away, but I do think was able to succeed on a high level by sticking to the goal, sticking to the course, sticking to the strategy.
So if I'm a PT 5 years out of school and I read this book, what do you think you'd hope the takeaways would be for that therapist?
So at CSM, I spoke about when evaluating your career choices or when evaluating your career potential transition point. We tend to there is a difference between happiness in your work and happiness with your work. And so happiness in your work is volatile. You can have a bad week. You can have an employer that doesn't fully support you. But that doesn't mean that you're unhappy with your work, where you have chosen this career, right? You have spent 5 years, and so ultimately you've spent 7 years getting there, and then another 5 years working there. So just because you may be unhappy with your position in your place right now, unhappy in your work, that doesn't mean that you are unhappy with your work. The strategy is still to be this ultimate clinician, ultimate provider. So you have to evaluate the long term, and set up a career path for yourself for the next 5 years that brings you to where you want to be. That's it's a long game, not a short game. Well, the score will take care of itself. Your career goals will take care of themselves as long as you are surgical in creating this architecture for the future of your career over the next 5 years, not in the next month, not in the next 3 months, not going after the lowest hanging fruit of this potential job that will get you paid a little bit more, but long term. And that includes being an entrepreneur. And potentially that does include leaving clinical care, but with a strategy, with a plan, not just a reaction to this availability of the one job that potentially has a way of paying you more short term, but the job will not develop you as a professional, not develop you as a clinician. And then a year later, you neither have the job nor the skill set, and you are lost, right? So then you become misguided or lost. So that strategy needs to be executed over time. It's a long game. It's a marathon, not a short race.
I would think some of that is knowing what to say no to also, right? If you're frustrated and you want to earn or need to or both earn more and something comes your way that you feel confident or relatively confident that you can be successful in, to avoid the temptation to jump at something without really fully understanding what's truly out there, and what that could lead to. And I think that's where this is part of that, strategy thought. It's as much about saying no probably than it is to saying yes, really knowing what that could lead to, even if you don't know, of course, you're not going to know it all, but to at least know that if you accept a certain role, doing something that seems doable for a higher salary, what are the options after that? Are there a variety of mobility within that organization? Does that open you up to, developing different skills to use, or do you want to maybe stay in that forever, but at least knowing more about how a decision about a next step in your career, how it leads to, your overall strategy for what you want in your career is probably, well, I would really like to read or listen to that book myself.
There's a way to frame a problem, and I think that would be my closing thought. That when you are framing your dissatisfaction with your work, and you can frame a problem using 3 questions. So you have to create a what it is that you want to do, or what it is that you are not happy with, and then do the now what. So what is the action plan? What do you do? And then you create a so what. That is the explainer. So what is that? Why is it that you're doing it? So what? So what, now what, so what? 3 parts. And then execute. Execute what brings you to that self-actualized sense of the way.
Awesome. All right. This was so much fun, and loved hearing about your experience at CSM. And we had some really great conversation.
Indeed. And I thank you for your time. This is wonderful. I really enjoyed this. Best part.
Me too. I enjoy it. Thank you so much, Alex.